I'm sorry I missed the start of the previous talk, but it's been a long journey from Manchester down to here. So some of my initial bit may have been covered, but what I wanted to do was to go over the Ebola response a little from the UK Med point of view and what happened afterwards, and then move from that into some points I'd like for you to consider about aid in general, maybe Africa specifically, and about capacity building. And if we are going to work in low middle income countries, then this needs to be a partnership, and it needs to be around capacity building. So you have a copy of my presentation, but the whole UK Med Ebola response is available free online. It's also in published form as well, in a small booklet. But all those of us who are involved in organising the NHS response have put all the information together. So I do take a photograph of that. I do get the copy of the slide afterwards, and then you can go on to the website there at the university, and you can download the full document, which incidentally goes into the costings as well. It was about 350 million, I think, that DFID spent in Sierra Leone. The actual Ebola treatment centres was a tiny fraction of that, 1% or something. It was very, very small cost. And we reckon, although you might think I would say that anyway, that it was very cost effective. But in the paper we tried to look at the relative costings of other overseas aid efforts and how it matches. And it does appear to be pretty cost effective. Get frozen. Okay. Right. So, to recap, UK Med is an NGO, non-government organisation that is based within the University of Manchester. We're a separate charitable organisation, founded in fact when we were working in Sarajevo during the war there, all those years ago. And the principle of the charity was that to give particularly emergency assistance in difficult situations, we needed experienced people. These events were not places to go to gain experience. We needed experienced people to work there. But experienced people who are on top of their game, have a day job. And so rather than people go out the traditional NGO route of going out for 12 months, 2 years, we would rotate people out for short periods, 3 or 4 weeks. But they would be seconded from the NHS, so their salary was paid. The cost of the programme would be in their transport and equipment and so on. So that was the model, and we rotated people in and out of the trauma centre in Sarajevo almost throughout the war, and that's the model. We've done that for various earthquakes and other conflicts. I worked in Sierra Leone during the Civil War, how many years ago? That was 10 years or so ago. So that was the model that we had, and when the Ebola response was required, Sir Bruce Keogh asked us, could we use our mechanism, which had really been around mobilising trauma teams, could we expand on that and our relationships with the NHS and the mechanism we had for getting their release and our training and so on, our insurance, everything like that, could we mobilise that and develop a more broader medical response, to which we said yes. And so we set up the UK International Emergency Medical Register for Ebola. And you would go onto our website and then you could log on, and if you wish to volunteer or you express an interest, then you would join on the website. Because the government was being urged to mobilise the NHS to support this programme, which is an interesting political step to take when there's so much pressure on the NHS. But from the very top, there was a willingness and a commitment to use NHS resources, so long as it did not impair the functioning of the NHS, to help in this crisis. I must say, when poor Pauline became ill and she was all over the news, my phone went and it was Bruce Keogh, and I thought, here we go, the programme is being cancelled. And he said, when's your next meeting with volunteers? I said, it's in London in 2 days' time. He said, right, I'm coming. And he gave a really moving and impassioned speech about this only galvanised the response to make it stronger. It was very impressive. We didn't actively recruit people. There was a letter from the chief medical officers that went round to trusts and to health boards. There was some media coverage, but we got lots of volunteers. Very quickly, and within a few weeks, we had to stop it. We had more. We got up to 1,643, but we stopped the recruitment because the NHS volunteers were not. No more were needed. They were spread, as you can see, across professions. What we wanted were people who could handle sick patients, difficult patients, could put drips up and so on, and were clinically experienced. And people came forward. They had 1 week's training in the Ukraine, which probably has been covered, and then there were 5 weeks in the Ebola Treatment Centre, and then 3 weeks of restricted activity on their return home. That 3 weeks of restricted activity was a big bone of contention for those who deployed. In order to allay public fears, it was more draconian than, in fact, the clinical need demanded. But we all have to manage the daily now. And they went to work in Ebola treatment centres. The first teams that went out actually finished building the Ebola treatment centres, because they came through UK Med, and then they went to work in a number of NGOs that were funded to work in Sierra Leone itself. The NHS was using our mechanisms for recruiting and training to garner people. What happened when they returned home? I don't know what your personal experience was, but Phil Tubb, who does our occupational health for us through the Liverpool School of Tropical Medicine, did a number of interviews. And the most commonly reported problem amongst the volunteers who agreed to be interviewed on the phone was social stigma. So you talked about social stigma within Sierra Leone. It was the same when they came back. Health workers being stigmatised by health workers who should know better. A number of volunteers are put under pressure by their workplace to have no contact with their co-workers during the incubation period, and were asked not to return to the hospital accommodation during the 21 days. This was pretty widespread. People were very upset, distressed and annoyed by this. Some people, because of one person was in the bank changing some money back. Oh, where have you been? Oh, I've just come back from Sierra Leone. They called the police. It was extraordinary. People were asked not to go to children's parties, there was a high level of anxiety, and the teams did suffer when they came back, although proved to be remarkably resilient in the end, because the group, as so often happens, seeks strength from each other. And I'm not aware of any longer-term problems. But it was not without risk. I'm so full of admiration for those who went. The spirit of altruism, the spontaneous altruism, the people willing to step up into most dangerous circumstances was extremely moving. And not without risk. Unprecedented number of medical staff infected with Ebola. But let's not forget, the main response, the principal response to Ebola was by Sierra Leoneans. They're the ones who were most at risk, they're the ones that had the largest number of deaths, they're the ones that kept it going. And it's very important when thinking about aid or assistance programs, even in acute emergencies, even very dangerous, that it's always the local people that provide the bulk of the response, whether it's the earthquakes I've been to, whether it's conflict, even search and rescue. It's well known that search and rescue after an earthquake, over 90% of those rescued are rescued by their fellow survivors, the local people. A further 9% by, greater than 9% by national teams. International teams, tiny, tiny amount. Nepal earthquake, 3,000 and odd international search and rescue people rescued 13 people. So get it in perspective, there were a lot of people saved, they were all saved by the Nepalese. So it just takes, it's not that the international teams aren't very good, they are good, it just takes too long to get there, it's all over in terms of search and rescue when you get there. So bear that in mind, it's the local people who are doing the work, but you can support the local groups if you find out what it is that's missing, what the gaps that need to fill. So a very important thing, whether it's an emergency or long term, is don't give what you have necessarily, give what people need, and there can be a difference, because what you have might not be what they need. Okay, don't go, find something else to do. And of course there were all the risks with the dead bodies, as you know. And because of an initial failure to understand how to work with these local communities, the burial practices were not understood, and the way the dead bodies were managed, which led to more contamination that could have been avoided. Interestingly enough, WHO now are looking at, should emergency responses in these circumstances have medical anthropologists in to inform people. So whether we need to go that far, I'm not so sure, but we certainly need to engage all the time with the local population. And moving away to why do these events happen? Why did Ebola happen? Well, Ebola is happening at intervals. It hadn't happened in that part of or in West Africa before. But Ebola, because of its high fatality rate, normally just burns out quite quickly, because it's in on the edge of forests, infections occur, high mortality, little movement of people, sadly not die, but what has happened with rapid urbanization and the movement of people into these large conurbations with poor sanitation and so on, then the disease could spread in it, even though the mortality rate was high, because of the density of the population and the proximity with which people were living with each other, it could still spread. Now that's poverty. It's not natural. So please, if one thing I'd like to take away is, can we all stop talking about natural disasters? There are natural phenomena. If it's a disaster, we failed somehow. And it's an important shift. We got rid of the word accident for the same reasons. Accidents implied there's nothing that you could do to prevent it. Not true. We talk about emergency departments and so on. We talk about road traffic collisions because it could be prevented. So let's do the same with natural and change our thinking. And why is Sierra Leone so poor? Because we know it's potentially very rich. Well, it's interesting. We quickly get back to days of empire. If you look at the countries that were affected in West Africa, Sierra Leone was managed by the UK because of our empire and our links with it. Guinea, France, going back to days of empire. Liberia, United States. These historical links that with these countries still play out now. And so, I'd like you to just read that. I wrote this in a blog and I tried to edit it down, but I thought I'd just let it read it. I'm applauding every single thing. How too often these disasters in lower and middle income countries being defended, especially the picture of heroic Westerners riding to the rescue of the hapless and the helpless. Not only is this a gross misrepresentation of these countries, their capabilities and their peoples, it's too often played out alongside history of the earlier actions or inactions of the West, having produced, contributed to, or exacerbated their vulnerability in the first place. And I think you were making that point you were. So no more. We need to work together as partners, supporting and strengthening our national systems and matching the emergency response with support to capacity building. We've got to change the mindset. There's a lot being done in the time, 30 odd years I've been doing this, attitudes have changed, but we need to keep maturing our response. Even going back to the British government's response, when I worked in Kosovo with the Department for International Development, when I've been working on the development of the emergency medical teams, we worked with Crown agents, and Crown agents supplied the empire, particularly India with all its goods, and became involved in humanitarian relief in 1969 to the Biafran War. You're all too young to that, but I was highly motivated by the conflict in Biafra, and where MSF was formed. Bernard Kouchner got Doctors Without Borders because it was a conflict within a country, and so the Red Cross wouldn't go in. Oh no, we can't, that's the sovereign country. And these French doctors said, we're Doctors Without Borders, we're going in. It was wonderful. It really galvanised me. And when I worked in Kosovo, I worked with Bernard Kouchner. I was one of the highlights of my life. And the scale of the operation prompted Crown agents to have a department solely engaged in humanitarian work, but it's linked back to the empire. The Overseas Development Administration, which preceded the Department for International Development, just to show you too that this is all linked to aid and trade and the Foreign Office. Sometimes it's in the cabinet, sometimes it's got a minister, sometimes it's not. It's only when the Labour government came in 1997 that there was this permanent separate Department for International Development to try and separate as much as possible the political concerns of dealing with other countries and aid and assistance for its own sake. Why am I saying this? Because I think it's important that we look at how we get involved with particular countries, how countries have ended up, how we can help, and look at what's happened in the past. I've said that about natural disasters, but what I want to add to it is that the vulnerability, so incidents occur, natural phenomena occur, but your vulnerability is largely based on wealth or poverty. And poverty, again, is not natural. People don't want to be poor. The extreme poverty you saw in Sierra Leone, there are factors keeping people in that degree of poverty. And so as healthcare workers, we have to be aware of this. We can't keep just solely putting aid in. We have to look at the other factors that make people so poor and therefore so vulnerable, because the poor are the vulnerable ones, and the very poor are the most vulnerable of all. And then these incidents occur, so not only are they vulnerable, they then become even more vulnerable. But there is an element of enlightened self-interest. Diseases that might threaten us over here can be contained over there. I mean, there was an element of national security about the Ebola response, make no doubt about it. And we need to recognise and promote the link between our safety and the vulnerability of others, and overcome any political, philosophical or fundamental separation and address the two together. We are one world. In spite of what Trump says, and in spite of building walls, we are one world. The internet sees to that. You press a button and we're all connected. So we have to work more closely together. Touched upon corruption, but it's a sad fact. It's related to the poverty and vulnerability. Perhaps the aid itself and the willingness to give more aid from those trying to help. Don't give up. Be critical. Don't be cynical. We have to tread carefully, preserve and maintain public trust, and spend our and your money wisely, but don't give up. Just coming to my field of emergency healthcare, the noise and the cries from outside of something must be done can matter please from inside of something that we need as an inappropriate care can follow. And that's another form of corruption to me, spending money on things that were not needed, let alone practicing on licence in another country and carrying out procedures for which you're not qualified. It's just another form of corruption. But this time, you're importing it. So do be aware of that. please work in other countries, please support them. But the usual rules apply. You have to be registered, licensed. You have to only practice and do those things which you are licensed and authorised to do in your own country. It can all be achieved, and you should do it. And make sure that what you're doing fits into the local health service. It's supporting it, not threatening the local health economy. I'm very aware when I go to disasters, for example, I set up a field hospital and I give care for free. What happens to the local healthcare workers? Do I have a national health service? Am I putting them all out of work? Well, it could be, but we incorporate them into our service. But you must be aware of the health economy and work to support it. But when you think about corruption, it's unlikely to be the poorest member of society struggling to get by that is at the heart of any national corruption. It's the elite, the already haves, not have-nots, that are stealing on a grand scale. Kleptocrats, I agree. Now, I would hate to see the final acts of treachery and theft by those at the top of society to be the robbing of the most vulnerable people at the bottom of any aid, as they distinguish economies and every Andy says. Just because aid can do harm, it is a moral and logical fallacy to assume that the absence of aid will do no harm. Think about that. But that's lying with them. Because aid is big business. 27.3 billion in aid. But whilst we are looking to monitor and hold to account those who are practicing and distributing the aid, what about those who fund it? Do we need to hold those to account? Recipients of funds are increasingly scrutinised, says Caroline finds, but the effectiveness of donors is not. So if you've got lots of money, let's not question how you might have got all that money by the NHS, Microsoft products, for example. But you can now then determine where the aid is given. Well, shouldn't you be held to account for that? And I think that's an important issue, that where those who are funding the aid programmes, how they are held to account, what is making them prioritise something over another, and how engaged with the local populations are they. Because we need standards. On the emergency side, we have the classification of minimum standards for emergency medical teams. But you can download this from the WHO website. But you will see the standards for practicing medicine in an emergency. They're quite clear. But these standards are just standards. So if we are working in these countries, we need to apply these standards. Because I alluded to this at the beginning, that my background is in A&E, emergency medicine, which are now, emergency departments are no longer places where those in need of training go to gain experience from those in need of care, but rather places where those in need of care go to gain from the experience of those already trained. That's changed in my lifetime. We used to be sent down to casualty. It's good for you to gain experience. Whereas now, that's all been changed, that's been turned on its head. We have specialists to improve care. And we need to extend this further to international emergencies and particularly to broader aid programs. It's experienced people more, because they can take their experience to these countries and train people and build capacity. And then you won't get inappropriate responses like in the Asian tsunami, where it was a very tragic event, but if you knew anything about disasters, you would know that tsunamis are not like earthquakes, that most people who are in the water and injured are drowned, because you can't be seriously injured and swim. Earthquakes, one person injured, one person dead to every 3 people seriously injured. Tsunamis, 9 people dead to 1 person injured. So the medical, but people, I suppose they were very moved by it, but there's a lot of aid went in that was not appropriate, and the Disasters Emergency Committee, when reviewing this, said, think about more what it is that will be of most value, which is often just giving money or training people, building capacity. You want to go and give of yourself, and sometimes, like in Ebola, that's what's needed, but sometimes it's other things. And concerns about inappropriate responses to emergencies are matched by inappropriate responses to aid in general. Kelly McQueen is an American anesthesiologist, writes very well on this, about people going out doing programs in low and middle income countries, but not applying the same standards of medical record keeping and so on that they would in there. So, there are negative effects of aid, whether that be acute or whether that be more development type programs. It can distort local economies, be aware of that. Can relieve the burden of provision from local governments. That will get the outsiders to come in and do it. Can create dependency, it can promote corruption, it can be inappropriate to local needs, and it can promote the superiority of the foreign over the local. It can do all those things. However, it can do an awful lot of good if you are aware of these problems, and I encourage you to do it. But it's a serious business that requires professionalism and engagement with the local population. And I'll leave you with that phrase here. I've used this slide for years, and I've read all of the books. And I was on a panel in Washington 3 years ago, and I sat next to it and I took a selfie, and I emailed it to all my students. Thank you very much.